In this voiceover PowerPoint, I'm going to talk to you about thyroid disorders. This is from the exemplar of hormonal regulation. The thyroid is responsible for basal metabolism. It increases the basal metabolic rate. It increases the body temperature. That's called calorogenesis. It increases appetite. Um, Carbohydrate, lipid, and protein metabolism. It promotes glucose catabolism for energy. It stimulates protein synthesis. It increases lipolysis. It enhances cholesterol excretion in bile. In the heart, it promotes normal cardiac function. In the nervous system, it promotes normal neuronal development. In the fetus and infant, it promotes normal neuronal function. In adults, it enhances effects of sympathetic nervous system. Musculoskeletal, it promotes normal body growth and maturation of skeleton. The thyroid gland is a butterfly-shaped endocrine organ consisting of two lobes on either side of the trachea or the windpipe. It's connected by an isthmus located just below the larynx in the front of the neck. The thyroid produces and releases its hormones into the circulation. The thyroid hormones thyroxine and triiodothyronine, that's T4 and T3, are essential for normal growth and development and for the regulation of metabolic rates in every cell of the body. Thyroid cells have a remarkable capacity of concentrating iodide against a steep concentration gradient. Iodide is found in many foods. In the U.S., we iodize our salt, but it's also found in other areas too. And that iodizing our salt actually helps to ensure against iodine deficiency in the general population. T4 and T3 contain 4 and 3 atoms of iodine, respectively. Specialized biosynthetic pathways leading to the production of these hormones incorporate the iodide into precursor molecules. However, most T3 is produced outside the thyroid monodeoidination of T4, and it's a removal of a specific iodine atom from T4. Normally, the concentration of T4 in the circulation is approximately 50-fold higher than the concentration of T3. T3 is approximately 5 times more physiological potent than T4. Nevertheless, T4 and free T4 measurements provide very reliable indications of thyroid status. The utility of T3 and free T3 determinations lies particularly in cases of hypothyroidism, the relatively narrow concentration of limits to ensure growth, development, and optimal health. A negative feedback mechanism designed to maintain optimal thyroid hormones levels operates along the hypothalamic pituitary thyroid axis. Disruption of the dynamics within and or between any of these three organs can disrupt normal thyroid function. The function of the thyroid gland is to take iodine found in many foods and convert it to thyroid hormones, thyroxine, T4, and T3. Thyroid cells are the only cells in the body which can absorb iodine. These cells combine iodine with the amino acid tyrosine to make T3 and T4, and the T3 and T4 are then released into the bloodstream and transported through the body where they control metabolism. Every cell in the body depends on thyroid hormones for regulation of their metabolism. The normal thyroid gland produces 80% T4 and about 20% T3. However, T3 possesses about 4 times the hormone strength as T4. Hypothyroidism, so that's when your thyroid is underactive. So the underactive thyroid gland, different types of disease, Hashimoto's thyroiditis, or different types of causes. Hashimoto's thyroiditis, autoimmune causes can cause hypothyroidism, surgical removal of the thyroid. Sometimes surgical removal of the thyroid starts as hyperthyroidism, and then it needs to be removed and they become hypothyroid. Radiation treatments, little intake of iodine. We generally don't see that in this country because of the iodized salt that I talked about earlier. some medications, and there can be congenital causes. Diagnostics, they may do a fine needle biopsy, so they're going to sometimes they call it they're going to go through the skin and take out a little bit of the thyroid to biopsy it. They may ultrasound it, and they may do a thyroid scan with radioactive iodine. Labs T4 and T3, thyroid antibody tests, calcium levels. The parathyroids are located within the thyroid, so that's why they'll check the calcium levels and electrolytes. They're going to check for free T4 index, TRH stimulation, and we talked about that in the hormonal regulation PowerPoint, and TSH. The idea is to measure the blood levels of T4 and TSH. In the typical person with an underactive thyroid gland, the blood level of T4 will be low while the TSH will be high because the body is trying to get more thyroid hormone or more T4. Some of the symptoms: intolerance to cold. I talked about this in the hormonal regulation concept PowerPoint. The body is trying to stay warm. They're dressed inappropriately. So let's say the picture that I've got here, let's say that was July in Florida. Maybe it wouldn't be quite this extreme in July in Florida, but it's that they're intolerant to any cold and they're overdressed for the temperature as far as layers of clothes. They may have a receding hairline, hair loss, facial and eyelid edema, a dark blank expression, extreme fatigue and apathy, lethargy, thick tongue, which is going to cause slow speech, dry skin, and it's coarse and scaly, anorexia, brittle nails and hair, muscle aches and weakness, constipation, menstrual disturbances, and late clinical manifestation. Their body temperature will be lower than normal. They may have bradycardia, which is a slow heart rate. They may experience weight gain, have a decreased level of consciousness, have thickened skin, and have some cardiac complications. So the diagnostic studies specifically for hypothyroidism, you're going to do a history and physical, and you're going to look at their appearance and their mentation and their facial expression. You're going to do TSH and free T4, and I said this already, TSH increases with primary hypothyroidism and it decreases with secondary hypothyroidism. They're going to do thyroid antibodies to determine if it's an autoimmune origin. Nursing diagnoses, they could have decreased cardiac output. You're going to assess for bradycardia, dysrhythmias, oxygen if needed, ineffective breathing patterns, care when giving sedation, disturbed thought processes, assess lethargy, memory deficit, poor attention span, difficulty communicating, constipation, and deficient knowledge. Pharmacological management, they're going to be on levothyroxine or Synthroid. This is the one that is known to work. Synthroid is also, if for some reason the patient's hospitalized and has to be NPO, you can get Synthroid, they can get that IV, but generally it's a daily oral dose. They will monitor their weight. They're monitoring their cardiovascular status. They will have to have lab work to stabilize their TSH and their T4. So monitor for hyperthyroidism to make sure they're not getting too much and that they're actually getting enough. Nursing management for somebody with hypothyroidism, we're going to assess the vital signs. We want to make sure that their heart rate's not too slow. We talked about the temperature already. Assess their nutritional status, including the fluid volume. Maintain a warm environment and alternate activity with rest. Because they don't tolerate cold very well, you want to make sure that the room temperature is suitable for them. Prevention and treatment of constipation, avoid sedatives, narcotics, sleep aids, encourage high fiber diet, and monitor for side effects of the medications. Hyperthyroidism, there's a few causes of that, and Graves' disease is an autoimmune disorder and it's the most common cause. It causes an overproduction of thyroid hormones. In patients with Graves' diseases, they have ocular changes. And I didn't put a picture in here, but it's that they get that exophthalmos, so it looks like they have bulging eyes. Um, they get lymphoid hyperplasia, localized abnormalities of skin and connective tissue, um, and the goiter itself. So that's what happens with the thyroid. It enlarges so much, they call it a goiter. The goiter represents part of the autoimmune syndrome. The remainder of the changes appear to be entirely attributable to an excess of thyroid hormone. Certain systems or organs, like the muscles and cardiac system, play paramount roles in the disease, but as far as can be determined, these changes are all fundamentally related to and dependent on the excess serum concentration of hormones. Often the presenting symptoms are weight loss, weakness, dyspnea, palpitations, increased thirst or appetite. Think everything is super, super fast. Sensitivity to heat or increased tolerance to cold or tremor. So just think about opposite of hypothyroidism. This is the person that's completely underdressed for the weather or the environment. Uh, Occasionally, a prominence of the eye or diplopia is the apparent symptom, and goiter may long antedate all other manifestations. Often, a relative or friend notices eye signs, goiter, or a nervous phenomena before the patient is conscious of any departure from his or her usual status. Diagnostic studies for hyperthyroidism decrease TSH levels, increase free T4 levels, total T3 and T4, but that's not definitive. And they will do a radioactive iodine uptake to distinguish if it's Graves' disease or other forms of thyroiditis. Thyroiditis. There we go. I could say that. The thyroid stimulating hormone produced by the pituitary will be the TSH will be decreased in hyperthyroidism. Thus, the diagnostics of hyperthyroidism is nearly always associated with a low TSH level. If the TSH levels are not low, then other tests must be run. Thyroid hormones themselves will be increased. So they'll get an intolerance to heat, fine straight hair, bulging eyes, facial flushing, enlarged thyroid. Tachycardia, so remember in hypothyroidism it was bradycardia. In hyperthyroidism, tachycardia. Increased systolic blood pressure, breast enlargement, weight loss, muscle wasting, localized edema. They may have finger clubbing, they may have tremors, they have diarrhea, and have menstrual changes. Nursing diagnoses include imbalanced nutrition, less than body requirements, hyperthermia, fatigue, activity intolerance. Potential complications include cardiovascular problems, impaired sleep patterns, impaired coping, and risk for injury. Nursing interventions, we want to assess their activity. We want to do vital signs. Remember, cardiac is important. Encourage rest, cooler room temperature. Monitor post-iodine treatments, may not take effect for days to weeks. Monitor lab values. Antithyroid medications include propylthiouracil, PTU, that blocks the synthesis of thyroid hormone. Iodine, SSKI, it reduces the vascularity of thyroid gland, and we'll give that SSKI for a couple of weeks if they're having a thyroidectomy. We'll give that for a couple of weeks to reduce the bleeding in around the thyroid. Beta blockers slow down the heart rate. Radioactive iodine therapy to ablate the thyroid or to make the patient become hypothyroid. It's taken orally, and relief of symptoms may take 6 to 8 weeks. Surgical management, thyroidectomy, post-op care, routine post-op vital signs. You want to monitor the airway because remember where the thyroid is located so that if there's any swelling or bleeding that happens, that can compress the airway. Place in a semi-Fowler's position. Monitor drain output. Monitor for laryngeal stridor and laryngeal paralysis. Make sure to check their voice. Monitor calcium levels because of the location of the parathyroids. Remember, check for tetany, check Chavostics and Trousseau signs. Thyroid storm is when they go into a crisis. It's a life-threatening event with a rapid onset. It's caused by infections, trauma, or stress. And the key features is fever. And when I say fever, they get a temperature of 104, 105. It's super, super, super high. Tachycardia, it's like everything is on speed. Their heart rate is just going fast, 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 fast. They get tremors, they get systolic hypertension. So their temperature goes up, their heart rate goes up, their blood pressure goes up. And it's very clear that they're in some kind of a crisis. We treat it symptomatically until we can get the other treatments on board, or getting them working that we treat. It's the same treatments for hyperthyroidism. Myxedema coma is the complication in hypothyroidism. The heart muscle becomes flabby, so they're getting not enough oxygen to their heart and brain. So my heart is not contracting like it should. And this is a life-threatening problem, and it results in tissue and organ failure. And certain factors can suddenly trigger myxedema coma in a person with poorly controlled hypothyroidism. These include drugs, particularly sedatives, narcotics, anesthesia, lithium, and amiodarone, infection, stroke, trauma, heart failure, GI bleeding. Hypothermia is abnormally low body temperature and failing to take thyroid medication as prescribed. When they present with myxedema coma, the body temperature is usually abnormal, and in many patients, the core temperature may be as low as 80 degrees. They may have severe mental changes, including hallucinations, disorientation, seizures, and ultimately deep coma. They may have significant swelling all over the body with swollen eyes, thickening tongue. So think of the symptoms of hypothyroidism magnified. Patients can also have difficulty breathing. They may have pleural effusions and pericardial effusions, and their heart rate may slow down, and its ability to pump blood forward can be impaired. Okay, that is the end of this voiceover.